So I'm going to present a case of an epithelioid sarcoma in the head and neck, which is a soft tissue sarcoma, a little bit different than the last case. So this case was of a 37-year-old female patient that presented a couple of years ago with a right facial mass. It grew slowly over 3 years, which speaks a little bit to what we were talking about earlier about sometimes delay of getting a diagnosis for a growing mass. They had a standard workup that led eventually to a PET CT that showed just the mass. And then this patient also had a single lung nodule that was actually biopsy proven to be a single metastasis for the patient. The patient underwent a radical resection of the mass in May of 2018. And then that pathology demonstrated this to be a high-grade epithelioid angiosarcoma. This was a 6-centimeter tumor and had negative margins. Because the patient had a single site of metastatic disease at this time, and because we thought that the histology was angiosarcoma, which is well known to be very aggressive in the metastatic setting, we elected not to treat with postoperative radiation at that time, despite normally we would in a case with a high-grade sarcoma that's 6 centimeters, even with negative margins. As I mentioned, the lung lesion was biopsied and was determined to be metastatic disease. So the patient went on a clinical trial and was treated with pazopanib for quite a while and did very well. And then shortly after they went on this trial, they added immunotherapy to the patient's chemotherapy regimen. Actually, the patient had complete resolution of that nodule in the lung and was without any disease. And then in December of last year, the patient then went on to have a local recurrence in the head and neck of where the prior tumor was. So at this point, really all that was left was this smaller local recurrent tumor in that area. Chemotherapy was tried at that time, and we were able to achieve stable disease with a couple of chemotherapy regimens. This is gemcitabine, taxane, and ADI, and then doxorubicin-based regimen. And then once we were able to achieve stability on this regimen, the question came up about whether she would benefit from resection of the recurrent tumor. So that was undertaken. The resection, before I jump ahead to the surgery, this patient had preoperative imaging that showed this tumor right here in the parotid space on the right side. This is a good image of it. Relatively small but recurrent, so 3.5 centimeters of maximal dimension. And then when we're worried about angiosarcoma or epithelioid sarcoma, we think a little bit about the involvement of lymph nodes in the neck. There was no evidence of that on the scan, so we moved forward to surgical resection of this disease. We decided up front to do surgical resection followed by radiation because a very intricate surgery was planned. The patient had a resection with a flap reconstruction, and I think in general at our center in the head and neck area, when we're planning a flap reconstruction, the preference is to use radiation after surgery versus before. So the surgical resection was undertaken in July. It included a right parotidectomy, a tumor resection, the right neck lymph nodes were evaluated with a dissection, and then as I mentioned, there was a free flap reconstruction. There was actually ablation of the external auditory canal with this surgery, so a bone-anchored hearing aid was implanted. These are devices that allow patients with damage or issues with their external ear to be able to hear on that side after a surgery. The only reason I mention this is it is an electronic device, so the bone-anchored part of this was placed during the surgery, and then the rest of the device that's on the outside of the body that's electronic was reserved to be placed until after we were done with radiation, so there was no damage to the device with the treatment. The pathology from this cancer, it was actually further classified as epithelioid sarcoma, which is different than angiosarcoma. And we were actually not very surprised by this because epithelioid sarcoma, while it's similar under the microscope, behaves a lot more like this case versus angiosarcoma. And what I mean by that is it has a propensity for local recurrence and well-behaved metastatic disease, whereas angiosarcoma tends to be highly aggressive in the metastatic setting. The final size was concordant with the imaging, and the tumor was found to be mostly viable, and the final margins were negative. despite the fact this is a small high-grade tumor with negative margins, because it was recurrent, that was the indication for radiation for me. So we just opened a new center, we just opened a new machine at our center called spot scanning protons, or IMPT. IMRT was reviewed very nicely in the beginning of this webinar. And the idea is that the IMPT, compared to older proton machines, is able to shape the distal edge of our fields very well. So in my opinion, this machine is really exciting for the head and neck location because, as you all know, the tissues inside the head and neck are very sensitive to radiation, and giving a high dose to those tissues is associated with a lot of side effects in the short term and the long term. So my fields are shown here. We delivered a kind of a shrinking field technique, which is standard in post-operative radiotherapy for sarcoma. The original location of the tumor was here. The blue is my lower dose field, and the pink is my higher dose field. And then what I'm showing you here is just a composite of the entire treatment to the patient. 60 gray and 30 fractions is the dose that I use as a standard in post-operative radiation therapy after a resection with negative margins. I just wanted to show the dose volume histogram, which is a way that we look at dose delivered to both the tumor and the normal tissues. And it's a little bit complicated to read these, but essentially what you're looking for is this shows the amount of dose delivered to the structure, the percentage of the structure. So up here is 100% getting the dose along the bottom. At the end of the day, what I want to emphasize here is that we like our target, or our tumor target, to be over on the right here at the top, where there's lots of dose going to a high percentage of the target. And then your normal structures are all down here, and that we like to see them over here with very little dose going to small amounts of the target. And essentially what I'm trying to show here is that things like the oral cavity, the salivary glands, which are very important for producing saliva in the long term, the optic structures like the eyes and the nerves that feed the eyes, and then those get very, very little dose with proton therapy in this sense. So this is really where I think proton therapy shines for patients with head and neck cancer, sarcomas, because it can spare these structures. I think that's all I have for you today.
Interesting presentation, Dr. Matt. So just because some of our audience are non-medicos, so I'll just summarize it in a very simple way. So in this case, there was a tumor on the cheek area, which is the parotid, near the parotid. And during presentation, there was also a lung metastasis. There was a lung nodule, right?
Yes.
So in this case, you started with chemotherapy and then planned for resection with radiotherapy. Many a times, a general question what is asked by a common patients is, if you are able to take out the tumor completely, then why do we need to give radiotherapy? So can you just elaborate about it?
That's a great question. I think this is an instance where we're lucky in sarcoma that we actually have clinical trial data to guide us. So the main reason that I do this is due to the factors that we know drive recurrences, and we know about these factors from studies of patients who have had surgery with and without radiation over a long period of time. So the things that we know make a high risk for a tumor to come back are a large size. In our case, large size generally means bigger than 5 centimeters. A high grade, and I think we've talked a little bit about grade, which is a score that the tumor gets that talks about how aggressive it might act. And then the biggest thing for me we've seen in our studies is that when a tumor has come back after a prior surgery, whether it's had radiation or not, that is actually the strongest predictor that it's going to come back a third time, in other words. So if it's come back a second time, the risk of it coming back again is quite high. This idea was actually tested in a clinical trial. So there was an old study where patients got a good sarcoma surgery by an expert. And then the question was asked, where half the patients got radiation and half the patients didn't. And we found that if you didn't give radiation, even after a very good surgery by an expert, the chance of it coming back was higher than most oncologists are comfortable with. So we typically will offer post-operative radiation therapy to reduce that risk.
Yes, right, very well explained that. And in fact, we know that when there is a tumor, there is a reactive zone around it. and probably there will be more satellite nodules or microscopic deposits beyond even the exact anatomical extent of the tumor, what is being seen on MRI or scans. So by surgery, we tend to remove it with a margin, but still there may be more satellite deposits around, which is very well taken care of by radiation therapy. So
That's an excellent.
yes, Dr. Mudit, just a question to you. So what is the role if tumor is recurring again and again? Do you think giving a conventional radiation therapy or using proton therapy, will it make a difference in those situations?
Yes, I think Dr. SPRAKER, he did hit on it, and I think you also hit on it as well. Once you come back, it usually has already declared itself as being extremely aggressive. And these type of tumors, you want to do your best to try to get rid of it completely the first time, so it never comes back, or if it comes back the second time, to stop it then, because once it comes back after that, it's almost impossible to control it. So I think in general, some radiation has a role. Proton therapy, specifically when you're asking, it really depends on the location of it. This is an extremely sensitive location that we saw, and I will have a similar case to Dr. SPRAKER, and we'll show like where we were unable to do proton therapy, and you'll see how the dose looks indifferently in our treatment compared to what Dr. SPRAKER did. But if you look at where his tumor was, like it was almost adjacent to the regular brain. The brain wasn't involved at all, so it doesn't need to get exposure to radiation if it doesn't need to. So the brain is starting right where his dose is ending. And then right in the central area, besides for the bottom of the brain, that's the start of the spinal cord. And the dose that Dr. SPRAKER is required to give to achieve control of this tumor is higher than what we like the spinal cord to get ever. So for example, we like to stop the dose at the spinal cord, ideally at 50 gray if possible. He's needing to give 60 gray to try to stop the tumor to come back. And you can see that in this case, the spinal cord is only getting 25 gray. So we have a very high level of confidence that we will not cause a big toxicity to the patient while trying to stop this tumor coming back, which would not be able to be as easily achieved as what, without proton therapy in this case, what Dr. SPRAKER was able to accomplish.
Yes, right. So yeah, that is very important that when we are closer to these critical structures, sometimes the toxicity can be more discomforting to the patient than the tumor itself.